All right. Hi, everybody. My name is Shreya Gandhi. I'm a first-year PhD student at the University of Toronto, and I'm just going to jump right into it. So growing up, I had a pretty amazing childhood. I was very close to my family and my friends, and on the surface level, everything pretty much seemed perfect. But a lot of things changed after my mom was diagnosed with a brain tumor. So shortly after her tumor was removed, she developed Bell's palsy. And that really took a toll on our family. So in 2016, I joined the Brain Tumor Foundation of Canada to just receive some support. And I was lucky enough to be featured for International Women's Day, where I met the first female chair of neurosurgery at U of T, Dr. Zadeh, who you can see here. And I was lucky enough to join her lab, and I'm now a PhD student under her. And we research glioblastomas and tumor microenvironment. Now, glioblastoma is just one example of a central nervous system tumor. There's actually a multitude of central nervous system tumors that are usually classified as per the genetic status of the tumor or a tumor biopsy that's removed, and the pathologist would determine the type of tumor. And these are all based on the World Health Organization classification of CNS tumors. So here you can just see a list of a few common tumors that you might have in the central nervous system. Now, the typical course of action for a patient is you have CNS tissue sampling. So surgeons might go in and take a tumor biopsy. That biopsy will be sent to a pathologist who will then grade the tumor. And then you might have a relevant multidisciplinary evaluation of whether you require chemotherapy or radiation or, of course, surgical invasion. And so the problem is that whenever you go into the brain, for instance, through an invasive biopsy, there's always risks. So our lab actually is working on something called methylation profiling, where we look at the pattern of chemical compounds called methyl groups that are attached to the DNA and use those to diagnose tumors. So what we do is we take clinically difficult or challenging cases that a pathologist might not agree on in terms of the diagnosis of a tumor. And our tumor board will take those cases and use methylation profiling to try and diagnose the tumor. So there is quite a bit of a complex process that's involved in determining this methylation pattern, but all we really need to know for the sake of this is that a tumor is removed, and at that tumor tissue, rather than the typical course that a pathologist would take, we would do a technique called CF-MEDIP, where we're actually able to look at the methylation profile of these tumors and based on the pattern, try to diagnose the tumor. And you can see that in many cases, when you had a challenging diagnosis, if you have an initial pathological diagnosis of, let's say, an anaplastic astrocytoma, which is a grade 3 glioma, after using the methylation profiling, the final diagnosis turned into a glioblastoma. So this is very therapeutically effective in perhaps changing the direction that therapy might take for these patients, because their diagnoses are becoming more refined through the methylation pattern. And then hopefully using that, we can develop an algorithm or a computational prediction model so that we don't even have to be invasive when we try to determine the type of tumor that patients have. So then what we did was we thought, okay, well, what if we use that same methylation profile, but rather than doing a biopsy, which requires surgical invasion, we just do a simple blood test. So what if we're able to just take blood from a brain tumor patient and then use the methylation profiling of the blood through something called cfDNA, or circulating free DNA, which is essentially just DNA that has no plasma membrane around it. You do a simple blood test, you separate the plasma, and then you take out the cfDNA, or the circulating free DNA, and then look at the methylation profiling of that, and then try to diagnose the tumor. Now, of course, it's a lot more complex than the way that I'm explaining it, but it's essentially a non-invasive way of diagnosing a tumor. So you take a liquid biopsy, or you take a blood test from the patient, you extract the cfDNA, or the circulating free DNA, purify it, analyze it through sequencing, and you can see that there's a differentiation of clusters between the different cancers. So this is very effective in using a blood test to cluster out different types of tumors. So this is just a little bit more zoomed in. You can see that based on the methylation profiling, you can clearly differentiate a meningioma, which is in yellow, to an IDH wild-type glioma, which is in green. There's very clear clusters here of different CNS tumors and their diagnoses. And then if you take this one step further, you can actually see that these purple columns over here, there's very clear clusters of different CNS tumors that you can detect based on this methylation profiling of this liquid biopsy or this blood test that you're taking from the patient. So you no longer have to invasively do a biopsy, which requires surgery. And so this really is a transformative form of medicine because you're no longer using a one treatment fits all approach, but it's more personalized because you're taking the blood test of each individual CNS tumor patient, you're using their individual methylation profiles or patterns, and then you're tailoring the therapeutic management course based off the type of tumor they have. So this makes it a lot more convenient for brain tumor patients because really it's just a matter of collecting blood through a glioma clinic, and then we would essentially take care of the rest. And so it improves quality of life because you no longer have to have a maximum amount of invasive procedures. So we actually do this at Toronto Western Hospital at a glioma clinic. So you just, if you're a brain tumor patient, you come there, you donate your blood, and then we do the sequencing, we do the methylation profiling, and we have an 84% success rate in determining the CNS tumor that you have, and in some cases, potentially changing your clinical course based on the tumor that we determine. So there's 3 leads in this project: Dr. Zadeh, who is my supervisor and my role model, Dr. Farshad Nasiri, another neurosurgeon, and my co-supervisor, Dr. Sheila Mansouri. And if you do want to donate blood or get involved in this is my email. Please do contact me. This is something that's still in clinical research, so we haven't been able to get it into clinical practice yet, and that's why we need your help. The more patient blood samples that we receive, the more we can validate this approach and essentially create a non-invasive way of determining a CNS tumor for a patient, and really take this basic research from a bench side to a bedside approach. Thank you.